connectivity, allowing to our patients to come back to a better performance status by the cognitive point of view in respect to the preoperative stage. And in fact, neurosurgeons strongly involved in the intrinsic brain tumor surgery are moving now their minds over a new concept, the supratotal resection, that was demonstrated impacting more and more the overall survival of our patients. What I mean is that the contrast enhancing area of this tumor, especially of course in high grade, is not is not the real target, but the target is to push as much as possible. And if you are able to push in the white matter this resection, the overall survival of our patients change significantly in respect to the median published, and the general neurocognitive trend remain totally unchanged. So our patients are, as you will see, able to have a normal life. To reach more and more better results in this field, we need, first of all, and this is my personal point of view, a new and real anatomical ground truth. You probably knows this amazing paper by Maxime and many of you that really changed the mind of neurosurgeons in respect to tractography. But we know that we all know that we need more and more confirmation of tractography results. We have extraordinary chance by the macrostructural, but also microstructural point of view. Microdissection is for sure a unique chance to confirm this data. We get the chance to work on that with reliable protocols of tractography, as you can see here. Microdissection already demonstrated to be useful to show and to confirm a new evidence regarding the structural connectivity, for instance, of the corpus callosum, demonstrating heterotopic fibers between different cortices of the human brain, but also with the basal ganglia. Macrodissection and tractography were merged before also to explore not so well-known structure like acoustic radiation, but also to improve, as Chiara demonstrated 5 years ago, and to drive new protocols of acquisition and trying to structuring reliable atlases of some of these structures. Now we are in a new scenario. We are able to acquire this data and to put all this information within a neuroradiological space. So to merge this information all together and to improve more and more, at least two aspects. The first and probably the most important, the didactics, especially for clinicians, of course, but even for people involved in brain science and basic science, and also the research. So the second point I would like to raise some apprehension regards the question of acquisition and processing. I really know you all are big experts about that, so I won't be very short about that. But I will highlight that this aspect is crucial, especially in the clinical ambient and more in the neurosurgical field. This is just an example for you of what was the evolution of the atlases regarding at least the most cited in the neurosurgical paper and in the neurosurgical community regarding probably the most well-known structure, projection structure in the human brain, like the pyramidal tract. This was the evolution in the last 10 years, passing through a deterministic to a probabilistic models, and so reaching probably more and more reliable results, especially in respect to a structure in which we have a lot of confirms coming from cytoarchitectonic studies and neurophysiology. But this is more and more important, you can imagine, for anatomy that we still doesn't know so we still don't know so well, like associative pathways or connection pathways. So Another important point regards the reconstruction, and this is very, very crucial in the clinical ambient. I just want to cite this paper by CART, this multi-group, multi-center study, but we have, a lot of confirmation about these results. And this is particularly true in the clinical ambient, where we need more and more easily and friendly tool for clinicians, and especially for neurosurgeons, to do it better, and probably to change our paradigm, as we are trying, for instance, to do with the tractome, that is a new cluster-based approach for reconstructing the pathways in the human brain. What we are trying to do with our group, for instance, is try to compare in the clinical setting what will be a ROI-based approach and a classical ROI-based approach, and a cluster-based approach could be better in the neurosurgical setting, using Track-Viz, that is very common software, very, very diffused even in the clinical ambient, and Tractome. What we used was a waypoints ROI-based approach and a cluster-based approach on 4 bundles. So the so-called SLF3, or indirect anterior portion of the SLF, the posterior SLF, AF, and the IFOF. And we tried to give quantitative and qualitative results between these two different bundles in tracking these in 25 patients. So this is, of course, some samples regarding the heuristic of the ROI-based approach for the AF and the SLF3, or posterior SLF, and the same regarding the IFOF, trying to to put this excluding ROI, try to reduce the artifacts in both the case in the deterministic spherical deconvolution and in a probabilistic spherical deconvolution. And we did the same also with the cluster-based approach. You see here a sample of the IFOF. We use the ACA irregularity in order to have a sort of a quantitative measure of our results. And what we discovered was that a cluster-based approach was better and better in obtaining more clean bundles and more reliable bundles. You can see here some sample also of the qualitative analysis of this data. You see all these artifacts of the AF that are fibers not stopping between frontal and temporal lobe, but going through the parietal lobe, that are very difficult to be removed with a ROI-based approach, and very easily to be refined on the other hand with a tractome. The same with if we look at the SLF3, for instance, or if we look at more and more, if we look at this shorter connection as in case of the posterior SLF. And what about IFOF, that is probably part of a larger inferior longitudinal system. So this is just to tell you that even in the less scientific part of the final results coming from tractography, we have a lot of work to do, a lot of proposition, a lot of new things to be to develop in order to go close to the clinical ambient and to the real medical use of this imaging. And I don't want to talk you about deep learning and artificial intelligence in this field. Our group also is working on that. And I have to be honest with you, we are very, very far to have something that can be very useful in clinics. There are after that, and so there is a lot to do, but there are also some intrinsic limitation of tractography. The first one is related to the fact that most of the time we are tracking, in this case, in a pathological system, and brain tumors are intrinsic, of course, by definition, but are really deforming the classical anatomy of the brain. And they produce also a total alterated signal around the tumor. And this is, of course, probably an intrinsic limitation that we cannot go beyond with the actual technology, and probably never. In this work in which I have the privilege to participate, thanks to Maxime that involved me, Van der Weyen and 14 explained very well which are the most important challenges regarding the intrinsic nature of intrinsic limitation of tractography in the neurosurgical setting. But we have a challenge more. You probably understand very well that we are also so interested to the functions of these bundles, because it's very nice to have a good reconstruction of the pyramidal tract, especially because we know exactly where and how to find it in terms of neurophysiological response. But what about all the rest of the tracts that we are providing in reconstructions in our department? I mean, neurosurgical, but also neurological departments. So tractography does not provide any kind of functional information, and so we need also this kind of feedback in order to say, okay, I have a very nice, perfect reconstruction of my AF, but what is the critical portion of this bundle in my case? What is the portion of this bundle that drive a particular function? So this is the reason why what most of the different group around the world is trying to match the unique information coming from the causal mapping of awake surgery with the anatomical information coming from tractography. You know very well that awake surgery strongly developed over the last 20 years all over the world, and it allowed to us neurosurgeons to improve more and more our results, because we are the unique chance to test the different functions at the individual level in that moment, and also to reorient our 3D imagery of that. So few years ago, we tried to this first attempt to delineate a probabilistic atlas, or what functions were related to different tracks using the atlas, the first version of atlas by Michel. So a few years later, we did something more. So we enlarged our population to more than 300 patients, so almost 700 subcortical response, merging this with the cortical response, trying to create the first real probabilistic atlas of the human brain in order to drive our structural information. What we did more recently and what we are trying to do is to merge all together, trying to create an atlas that is based for the first time on the causal mapping of the direct electrical stimulation for different functional categories on a large healthy population of 1,000 patients, in order to have this probabilistic distribution of the function all over the brain at whole brain resolution. We published this first attempt that obtained very good results, even compared with other clinical data like TMS or stereo AG or DES causal mapping. And what we are trying to do now is try to merge this with tractography, using as drive-through the points of subcortical, the points of functional subcortical stimulation. This is in order, we are trying to do that in order to understand better and better which parts of the different longitudinal system in the brain, superior or inferior, are involved in which of the different sub-elaboration of language, different sub-elaboration of motor functions, and so on. So you understand that it's not just a question of anatomy for us, but just also to try to merge together the structural information with the functional information, because this is more and more crucial in the clinical ambient. And these kind of efforts start to give some results. You see here, for instance, that these disk-derived network are able to capture the variation in the postoperative language recovery more accurately than canonical clinical measure in glioma patients. So we are slowly coming to some results for different functional networks, or let me say sub-networks, to be totally honest. So let's go to the practice. So it was a long introduction in which I really don't want to be to appear discouraged about tractography. I think that this is really an important tool, and we need more and more data regarding, especially regarding the sensitivity and specificity, sorry, of this tool in the neurosurgical setting. We have to understand more and more regarding which kind of algorithm is perfect or I'm sorry, is better to, for instance, track the associative pathways, which one to track the projection pathways, and so on. And I tell you that because we did a lot of passing of steps forward in respect to just 15 years ago when I was a young resident. I finished my residency in 2010. And this kind of measure, 3 centimeters on the left side and 4 centimeters on the right side, was the only measure that I found on the neurosurgical atlas, neurosurgical books, to perform a temporal lobectomy. So we did more and more, and as you will see soon, in the planning of our surgeries, in the predictive role of tractography regarding the outcome of our patients. So this is, for instance, the kind of setting that you can have now in a modern neurosurgery, in which you have a reconstruction, of course, of the tumor, or reconstruction of different bundles that you can be interested, of course, according to the cognitive status of the patient, according to the deficit of the patient, to the performance of the patient, and to the general cognitive assessment to our patients. And so you can have under continuous control, of course, the surgical field, but also the patient performance, the kind of testing that he is performing, and in the end, on your neuronavigation, all this kind of structural and functional information. So you can imagine that almost 20 years after starting my residency, we can say that you did a great job, guys. We have more and more information, and I will show you now as we try to use this information in our clinical context. So the case that I will show you now were tracked with an absolutely normal basic scanner. This is a GE scanner, 1.5 Tesla. We have 60 duration and B1000, and we use this kind of protocol since 2013 now. So what we decided to use, but we will have soon some data assessing the sensitivity and specificity of this choice, is a deterministic spherical deconvolution for associative pathways, because it reduces the false positive, and this is crucial to have a clean prediction and not so rumorous data and rumorous reconstruction in the clinical settings by my personal point of view. And we use a probabilistic approach to reconstruct the pyramidal tract. So this is the first case, the first practical case I want to show you. This is, by the surgical point of view, an easy case. We have a grade 4 glioma, so a glioblastoma. This is a wild type tumor, so this is the worst prognosis for our patient. And you see that this lesion is just at the level of the sorry, at the junction between the posterior two-thirds of T2 and T3, so the middle and inferior temporal gyrus. This is a critical region, as you well know, for the integration of the language elaboration by different point of view. And you can say, you know, okay, it's very easy, this is superficial, this is small, you can stay in the tumor and remove that. But we know that if you are experienced neurosurgeon, you need to do the best, even for these patients, because you can prolong the survival of this patient. You have, of course, to ensure to this patient the best prognosis in terms of neurocognitive outcome as possible. And so, what is the real limit of this lesion? The real limit of this lesion are the functional, subcortical functional boundaries of this lesion, as you will see here. So we have a good prevision, or what was in this case the course of Arcuate fascicle that was divided, sort of splitted in two branches, and below this you have the ventral pathways constituted by ILF and IFOF in this region. So this is the tumor, and you see this red area that is the possible real limit of this supratotal resection. So of course we cannot do a blind trust in tractography about that, but this is very useful because we really can understand where the bundles are located in respect to the tumor. So this is particularly important for neurosurgeons, especially for the less skilled neurosurgeon in the field of white matter dissection, and even in the functional field, because they have the chance to predict which will be the region where to stimulate. So I arranged for you some video. I really hope you can hear. You see here, this is a classical speech arrest to set the threshold. Just let me know if you listen the audio, Chiara, of the movie.
No, and we don't see anything now.
Yeah, but look, do you listen the audio or not?
No, we can't
No.
hear.
Typically, it's when you share your screen, you have to activate like transmitting the audio from the computer. So if you want to try, you would have to unshare and share it back. And I think there is an option to say like forward the audio or transmit the audio.
Okay. Like that, maybe. Let's try again. Can you hear me?
We can hear you.
Can you hear me?
Yeah, we can hear you. We
Yes.
don't.
We are seeing just a white bar.
Can you hear me?
Yeah, we can still hear you.
Yes. Oh, we broke it.
Can you hear me?
Yes.
Can you hear us?
I,
No.
No. No way. Sorry, guys. Can you hear me now?
yes.
Okay. Sorry, it's impossible maybe to let you listen the video, but I will try to explain you.
Do you have earphones, or are you on your speaker?
Yeah, I have the earphone now because with the speaker it doesn't work, so I don't know why.
That's why we can't hear, I think, because it goes through your earphones.
Okay,
Go
so
through the computer speakers, then we'll hear.
better now.
We
Wait.
can still hear you. Let's see if.
Okay, let's see the video.
Nope, we cannot hear it.
No.
Well, I have a feeling. I have a feeling it won't work easily. So yeah, maybe try to describe it.
Yeah,
So,
okay. Okay, so let's share again. Okay, so Can you hear me now?
Yeah.
Okay.
Yes.
But not the audio, is it?
No.
No, okay. So, but it was just to show you exactly what is the technique to evoke the first functional response, and then you see this is normally a speech arrest in the ventral premotor area or in the inferior parietal lobule, and then we move to the subcortical mapping during the resection. So you see in our planning that we were strongly interested to the fibers of the arcuate fascicle that we know at least in part are involved in the phonological loop. And in fact, the first thing that I'm doing here is trying to test this posterior and lateral limit that we found in tractography. And in fact, I found this kind of phonological paraphasia. So the patient is saying butterfly instead of strawberry. That is not in English phonological paraphasia, but is in Italian. And you see that after that, we are going in depth, okay, because we were able to resect the deeper part of the AF, and we are moving to the inferior longitudinal system fibers, particularly ILF and IFOF. And we are we really know that these fibers are strongly involved in the semantic elaboration. And in fact, if you look here, we are stimulating and we are finding this kind of fibers. So beyond the tumor, we found our limits, and we can stop now sculpturing these inferior longitudinal system fibers and evoking semantic paraphasia and anomia all over the surgical field. So the resection is now closed, and you see that it was in the end according to our tractography, but we have to make the link between the functions and the structures, and we have to be totally sure that our planning was correct. And of course, direct electrical stimulation is the only way. But you see that the surgical results is very good, and we did a resection over the contrast enhancing area. This is another case. This is a grade 2 astrocytoma. So this is an infiltrating tumor of the superior parietal lobule on the right side in a right-hander young guy. So you know that these kind of tumor are particularly challenging in neurosurgery because most of the time you can find functions within the tumor. On the other hand, if you look at the reconstruction, you don't find, of course, fibers within the tumor, okay? Even if you push with your tractography, like in this case with probabilistic approach. But this is not the real problem because, you know, in this case, tractography is once again very useful because we know exactly two things. The first one is expected, and so that the most of these afferent fibers to the postcentral gyrus are anterior to the lesion, but also that we have a splitting by the tumor of some fibers coming of the sensory system coming lateral to the tumor. So what we did was the same. We are going to wake our patients on the after the craniotomy. We evoked a threshold, in this case, directly on the sensory strip, because, you know, it's very easy to evoke some paresthesia in our patients. So we mapped, first of all, the sensory strip, as you can see here. And so we confirmed that this is anterior in respect to the, sorry, that this is anterior in respect to the tumor. Okay. Okay, you see here that we add the mapping of the somatosensory area, and we have here the tumor. And you see that we did not find in this lateral part, in which we are more and more interested because we have some infiltration by the tumor of this area, according to the tractography data, we did not find cortical response. So what we have to do is that we have to be very careful at the subcortical level and to use this information coming from tractography to avoid damage even to these fibers. And what happened was very interesting here. You see that we mapped, first of all, the fibers going exactly at the level of the post-central gyrus, and then in this third video we are moving more lateral, and the patient say, okay, I feel some paresthesia on my knee, I feel some paresthesia on my foot. So you see here we are much more lateral in respect to the post-central gyrus that is here limited by the post-central vein. Okay, this is the final proof that the patient say, okay, no, guys, I feel a lot of dysesthesia in this area, so you have to stop your resection. And so we stopped. A final check, even in the depth of the cavity that you see here, tractography showed this fiber arching below the tumor, and the resection was very good. Even in this case, we obtained a supratotal resection perfectly drawn at the limit with the posterior sulcus and of the fibers that we reconstructed with the tractography. So once again, it was useful. It was not a blind trust, but it was very useful to establish, you know, a marker, a warning more of our resection. This third case, this is an intriguing case. You see this very large, you know, few years ago, we could have defined this low-grade glioma just looking at the MRI. To be honest, this is of course a grade 3 IDH1 positive astrocytoma, frontotemporal insular astrocytoma in a young man. So what we do in this case was to reconstruct the tumor and the edema that was around to the tumor. You know that a big challenge now in the neurosurgical, especially neuro-oncological field, is try to distinguish between edema and the real infiltration of the tumor. But we will see in this postoperative control that we get in this case a positive surprise. But anyway, what my collaborators do every time is try to reconstruct the entire area, especially in order to understand how much does it really impact on the tractography reconstruction. You see a good reconstruction, especially considering the volume and the signal of this tumor, and we had a good representation of the arcuate fibers. We were very interested in this case to the frontal ascending tract, because you know now this is very well monitored, especially in terms of speech planning and speech articulatory network. But of course we don't have probably the most important information in this case, that is the fibers of IFOF that is totally cut here. The algorithm was not able to follow the fibers in this hypointense area, and in fact we have these yellow fibers that are totally cut at the level of the stem with just a small representation. IFOF is crucial in this kind of resection because it represents the medial border, and you have a lot of semantic disorder if you impact on that. So once again, we operated this patient awake with this planning. I don't know why this is so slow now. Maybe it's too much. Okay. Okay, I'm sorry, I have to go manually because it's too slow. But anyway, you see once again we had a speech arrest, so we set the threshold of this large tumor. We had the reconstruction of the bundle that I showed you within the operative theater in the neuronavigation in our neuronavigation, and we started with the resection. it was a huge resection, as you can imagine, and we are looking exactly for what we lack in this reconstruction. So what is the real deep border that we cannot see with tractography? Where is the IFOF in the depth of the surgical cavity? I'm so sorry because the video are very impacting maybe too much the connection. So once again, we are stimulating, and then in the end, you see here that we find the patient is performing a double task in order to test also his attentive and executive performance. And in the end, we find here, you see, this is the first step in which we find this is the border between the frontal lobe and this is the border between the frontal lobe and the insula. This is we are within the insula, so this is the external capsule, and we are stimulating the fibers of the IFOF stem coming within the frontal lobe and reaching the dorsolateral prefrontal cortex. And the patient start to say, okay, I have some anomia, I'm not able to denominate this, so we stopped here. And what was very interesting is that even the resting state functional MRI was not able to find the termination of these fibers that we followed all over the surgical field until its cortical termination at the level of the posterior third of the middle frontal gyrus. So all the functional limits were reached. Once again, we did a very good job here because you see that in this T2 flare that we removed 95% of the tumor, excluding exactly this deep part of fibers of the external capsule, fibers going to the frontal lobe that are in fact at the level of the stem of the IFOF. So a fourth case, this is an impressive case. This is probably the biggest challenge for neurosurgeon involved in brain tumor. So this is a glioblastoma of the insular region, a pure glioblastoma of the insular region, because this is a big challenge, because these kind of patients have not a long survival because your resection is strongly limited by strict functional borders at cortical and subcortical level, and this is especially true in the hemisphere specialized for language, like in this case. So the tracking in this case is very hard because all the structures are very compressed. Most of the times this can be also infiltrated, but you know that once again we have important information. So first of all, we know that the posterior and deep part of the tumor reach the pyramidal tract, and this is very important, you know, because this is crucial for the surgeon to understand that during the resection we have also a motor checkup to do in this case, and in which part of the surgical field is better to concentrate this kind of monitoring. On the other hand, we are obsessed by the IFOF, because cutting the IFOF at the level of the stem, so when it runs from the insula and the external capsule to the frontal lobes, it means for the patient to be totally unable to speak and to have a good semantic elaboration. And you see that even in this case, I will be very fast, because I understood that the connection is not able to sustain this kind of video, that after this speech arrest, we moved quickly to debulk the tumor, because the frontal area was free, and we go... Okay, and we go fastly in the depth. This is the tumor you see here, and we start to see some good brain parenchyma, and we stimulated, and the patient was unable again to denominate. So this is once again our limit. The patient was able to speak at the end of the surgery. We remove entirely the tumor, of course, not possible to do supratotal resection in this case. You see here the results of the mapping with this tag that is in the depth of the insula that was totally empty now after the surgical resection. This is the temporal lobe, this is the frontal lobe, so the approach was through the pars triangularis. So this is the motor strip, and the patient was once again I'm very sad that you cannot hear this video, because the patient was 3 or 4 days after surgery able to speak and to play guitar and to say thank you for these results and to come back home. So just to close, what we have to do, what you have to do, because we can just bring our needs and our experience in the brain anatomy and surgery. We need to improve more and more acquisition, and this is especially true in the clinical ambient. Trust me, I'm invited to thousands of meetings over the last year, clinical meetings, and there is a lot of confusion regarding acquisition, elaboration, and tracking, and even reconstruction. So we have to do that. We need some recommendation. This is very important to have some rigor and stringent recommendation. We have to altogether improve more and more the knowledge of the anatomical ground truth, because we have some doubts even regarding the taxonomy, the nomenclature of these fibers, and it making a lot of confusion, especially in the clinical ambient. Tractography is very useful. This is my conclusion. This is not a blind trust. You cannot say, and a lot of people say, especially my colleagues, okay, I have tractography, I'm very evoluted, I can go in the surgical theater with any kind of other monitoring. This is not the truth. Tractography is useful for at least 3 things in the neurosurgical setting. First of all, learning of the white matter, that is crucial, because medical students and residents in neurosurgery, but also in neurology, don't study enough the structural and functional connection of the human brain. I never will be bored to say that. Second, this is crucial. It's an extraordinary tool, and this is especially true for the people that has not access to microdissection and did not get the chance, like me in my career, to dissect more than 500 brain. It's very useful to create the 3D mental imagery of the relationship between the fibers. And this is crucial for a neurosurgeon, because since many years ago, and unfortunately still now, a lot of surgical planning are focused on the tumor, but we are in a new era. We are focusing on what is around the tumor, how to resect what is around the tumor, how to preserve what is around the tumor. And of course, for the preoperative planning, and I really hope to have showed you some cases in which tractography was very useful. Of course, if you have a knowledge, if you have an experience regarding the anatomy, the possible occurrence of functional response in the different, across the different kind of fibers. What we need, a lot of honesty, a lot of rigor and stringent recommendation, and I'm pretty sure that you will do a great job with the IST, especially to be in contact with the neurosurgical community, with the most important neurosurgical community, to grow more and more together, all together, to obtain better and better results for our patients and for your studies. So before to close, let me thank my collaborators, PhD, postdoc, neurosurgeon, neuropsychologist working with me every day, and people who is supporting us since many years with collaboration and funds. Thank you very much.
Thank you, Silvio. That was great. All right. We want to keep this as interactive as possible. So please, if anybody has any question, just unmute yourself and ask the question. I can start with one, just curiosity. Is there one single development since you started using tractography in your career? Is there one single thing that changed, or like an advancement that made a difference? You were like, okay, now I can do something that I couldn't do before, or this actually changed my practice?
To be totally honest, Chiara, I think that the best change was the chance to have spherical deconvolution data. Spherical deconvolution data are not so cited in neurosurgical papers, but I think on my personal view, it was a big change, and especially in depicting the associative pathways and the pyramidal tract and all the lateral portion of this important bundle. I think that it was the real step forward. Of course, as I told you before, when you start to use probabilistic data with spherical deconvolution, you have a lot of things. It's too much probably for a clear neurosurgical planning, but I think it was a really step forward.
Okay, so because you could see more things that you couldn't before.
You can see better, you can see more, especially where you have a lot of edema, a lot of mass effect, is more accurate. And even if you sometimes see some broken fibers, but even you see the case in which I showed this big glioblastoma of the insula, where the IFO was totally cut. But at least you know what is the location of the IFO in respect to the equator of the tumor. So you can imagine that the fibers are below on this projection. So this is very superior in respect to the deterministic to the classical DTI.
Okay. Anybody else? Yeah, please.
Silvio, thanks for the talk. Do you see a day where awake surgery could be stopped and just purely based on planning from imaging data? Do you see a future where this would be possible, or you will always, you think, wake up your patients?
I think, Max, that I really hope we will have this future, because of course this is a big work to do even for the patients, and especially because I just showed you awakened patient, but especially to give you the real sense of about the fact that tractography match with the most of the reconstruction, if you really know what you want to find and which kind of function these bundles observe. But to be totally honest, you have to know that more than half of the patients affected by glioma, even if treated by a trained neurosurgeon like me, cannot be operated, cannot be awakened. So all these patients are operating now with the preoperative planning that is very variable. The most evolved centers have some resting state or task-based approach. Someone has TMS that is very useful. TMS and tractography, resting state tractography, even in our case. But you cannot do a blind trust even still now in this tool. So in the end, you operate these patients, and the results are not different, to be totally honest with you, in terms of cognitive outcome. I showed you. The difference is that in the awake patients, you can push more and more. So I really hope that you will give us something more and more reliable, but I think this is a work to do together.
Joseph here. Let's say a few words. Thanks for an excellent presentation. It's really great to hear from our neurosurgical colleague. And I might sort of start by just maybe respond to part of sort of relate to Maxime's question about whether there will be a day of surgical planning without direct intraoperative mapping or awake surgeries. And I think it's very scenario situation dependent. Now what Silvia has talked about is sort of very focused on adult glioma practice, high grade, low grade. But in our center, for example, we are pretty much the opposite, pediatric, mostly sort of epilepsy surgeries, Where in children, so rarely you get a situation you can do awake surgery. So in that case, very center specific, very practice specific, then what we rely on is, really, state of art, probabilistic CSD-based tractography with task-based and resting state FMI, trying to get to a point where we could, formulate a adequate functional / structural, surgical strategy. And we have shown that, at least in our center, in our hand, we could achieve really good functional outcome for things like, challenging surgery in eloquent region or dominant, language dominant insular region surgeries, for example. But I stress it's a very different surgical scenario, and there are, very situation dependent and obviously your patient dependent. But coming back to Silvia's presentation, I think I absolutely agree. The very last slide about the, what would still need to be happen. And I encourage you all to also check out a paper from Hugh Defoe's group, it's about tractography learning for neurosurgical trainees, and he sort of titled it as an a la carte for surgical training education. And I think it's really important for neurosurgical training to actually learn better with, in terms of white matter anatomy. And I think what Silvia and his group put out in terms of the 3D resource is a really excellent resource for education. I've got two questions for Silvia. Is similar to, it's really, really wonderful, and you sort of touch on that in terms of neurosurgery, moving on towards more a lesion-based to a more connectomic-based understanding of a surgical practice. Do you think there will be a point where the more we understand, the more, I don't want to say scared, but the more we understand, the more we start to think about perhaps there may be some sort of functional structural hierarchy that we may need to, when we are pushing the boundary, we may need to make difficult decisions to say, in scenarios where you'd be, okay, well, there are certain function and tracks involved in this region, and we may have to sacrifice certain function to do that. Do you have any comment on that?
Yeah, I have two comments, Joseph. First of all, regarding your comments, and what you said is true, but you have to remember that most of the time, the brain of pediatric brain is not the brain of 40 years old, unfortunately for 40 years old guy like me. So it's very plastic, and you can push more, and is generous. Okay, so are not sectors totally comparable, to be totally honest. Regarding the question, I think yes, I think we are doing a lot of progresses about that. I was impressed over the last 10 years when I listened to the Hugh in different congresses. You know, probably Hugh is my master. A lot of Italian and worldwide colleagues saying, okay, this is a stupid story, IFOF does not exist, we cannot map the functions, and so on. And now we know that we have neurosurgeons all around the world that can do this kind of causal mapping in 50 minutes, and to improve more and more their results. And even when I remember we published the first version of the atlas in 2015 in human brain mapping, I want to totally be honest with you guys, thank you neuroscientists, because it was the only journal that accepted that paper. That did the prestigious round of review on big medical journal, but in the end the problem was, okay, but we don't have the negative points, so we cannot assume that this tractor really drive a functions. And we know now that it was the true. So now the challenge, the challenge is to make the different pieces of the puzzle together. That was we are trying in our group, for instance, with resting state, causal mapping, and tractography, in order to say, okay, probably I'm not interested to all the AF, but maybe in this patient, or with task-based fMRI, for instance, that is very useful, or TMS, that is more focal, but I'm interested on this group of fibers, and I have to preserve this. So we have, of course, do a lot of work. We have to test the sensitivity, and especially the specificity. I'm not boring to say that of these methods, but we are doing straightforward.
Thank you.
All right. So it's past 10, so I think we can end here. Thank you all for coming. Thank you, Silvio, for the presentation. Just a reminder again that there will be no Tract-Anat-Club for July and August. We'll be back in September.